Hi everyone, thank you for joining us today and welcome to this month's Lunch and Learn research seminar on the early childhood development and adult disability support, building effective services and systems. I'm Jessica Stewart, Executive Director of Family and Community Services, Insights Analysis and Research, also known as FACSIAR in the New South Wales Department of Communities and Justice. Before we begin, I would like to acknowledge that wherever we are joining today's webinar from across New South Wales and Australia, we are all living and working on Aboriginal land that was never ceded. I'd like to personally acknowledge the Bidjigal and Gadigal people, who are the owners and First Nations people of the area where I have the privilege of joining you today. And I would like to pay my respects to all First Nations elders past and present, and extend that respect to our Aboriginal and Torres Strait Islander colleagues joining us today. I'd also like to warmly welcome all of you. Thank you again for joining us this month. We have had a great response for this webinar with over 800 people registered, and it really just does demonstrate the importance of this session to you all. Today's FACSIAR Lunch and Learn webinar will focus on how service systems can better support people across the life course, from equitable access to early childhood development services through to high quality disability support for adults. I'd like to also welcome our presenters today, Professor Sharon Goldfeld, Director of the Centre for Community Child Health at the Royal Children's Hospital, Melbourne. We'll explore where and how interventions can be most effective, from developmental promotion and early detection through to prevention and early intervention, focusing on how good service design can help prevent inequities. Emeritus Professor Christine Bigby, AO, Founding Director of the Living with Disability Research Centre at La Trobe University, will then talk about quality in service delivery, with a particular focus on support for everyday living for adults with disabilities. Drawing on research and practical examples, she will discuss what constitutes good quality practice with clients, how it can be embedded in program design, and how we can better measure outcomes. Following the presentations, we will have a panel discussion with Fiona McEwen, who is the Manager of Service Design at the New South Wales Trustee and Guardian, and Catherine McKenzie, who is the Director of Operations in the New South Wales Ageing and Disability Commission, on the implications of the presentations for policy and practice across sectors. We also have Jerry Sheeram and Marnie Wood, who will be our Auslan interpreters during the session. If there is anyone in the audience who would like to pin the interpreters for ease of viewing, please hover over the video feed of the person you want to focus in. Click the More Options button, which is the three dots at the top next to their name, and select Pin for Me. This session is also being recorded and will be posted to our FACSIAR webpage. Anyone who is registered for the webinar will receive the link to the recording within about 1 week. Now, we have a jam-packed session for you today, so we will now move to introducing our wonderful presenters. So Professor Sharon Goldfeld, as I mentioned, is a paediatrician and director at the Centre for Community Child Health at the Royal Children's Hospital and theme director of population health at the Murdoch Children's Research Institute. Sharon has a decade's experience as a senior policymaker in the Victorian Health and Education departments. Emeritus Professor Christine Bigby, AO, from the Living with Disability Research Centre at La Trobe University, has a long track record of working in partnership with disability support organisations, investigating the effectiveness of practice, social programs and policies that aim to support the social inclusion of adults and older people with intellectual disabilities. She has published extensively in the academic literature and translated research evidence into a series of widely used online training courses for disability support workers and organisations. Fiona McEwen is the Manager of Service Design at the New South Wales Trustee and Guardian, where she works with frontline and enabling teams to improve services for people navigating complex systems and life circumstances. With experience across the public, private and not-for-profit sectors, Fiona is passionate about inclusive design and ensuring the perspectives of people whose voices are often absent from shaping services and priorities are heard. She uses design approaches to bridge community experience and organisational decision-making. And finally, Catherine McKenzie is the Director of Operations in the New South Wales Ageing and Disability Commission, where she has responsibility for the breadth of the Commission's functions, including the helpline, community supports and investigations, communications and engagement, and the official community visitor scheme. Prior to her role at the Commission, Catherine was Director of Disability in the New South Wales Ombudsman's Office and held roles in service provision, investigation and oversight, including the Community Services Commission, ICAC, the New South Wales Public Guardian, and NGOs. We have a fantastic lineup today. Welcome to you all, and thank you so much for agreeing to be part of this really important webinar. Can I please ask anyone if you have questions that you would like to ask our presenters or our panel members, please just put them in the chat, and they'll either be answered in the chat or I will come to them during the Q&A session if we have time at the end. So I will now hand over to our first presenter. Please go ahead, Sharon Goldfeld.
Thanks so much, Jess. And can I just say, I feel doubly honoured to be here at a New South Wales seminar as a Victorian, so that feels kind of doubly honorific. And so thank you for allowing us to join you today. I've got a lot of PowerPoints, everyone. Don't panic. I go through them really quickly and they'll all be available afterwards. So they're just a way of kind of telling a story. And if you're sitting at home or sitting at your office eating lunch, you can just kind of watch a story unfold. I also want to acknowledge the traditional owners of the land. This is a lovely piece of work, actually, that was done by an Aboriginal artist in the Territory, but just acknowledge that I'm on the land of the Wurundjeri people, Kulin Nation, and pay my respects to elders past, present and emerging, and any First Nations people here with us today. I also want to anchor us in children. I think you've got this lovely sort of ability. We're going to talk later about adults. I want to anchor us in children. So I always like to sort of remind us about children. Gabriela Mistral's a Nobel Prize winning poet, and she says many things we need can wait, the child cannot. Now is the time. His bones are being formed, his mind is being developed, his blood is being made, his mind is being developed. To him we cannot say tomorrow. His name is today. So let's start with a kind of global perspective on where Australia is kind of going. So these are reports that have come out from the UNICEF Innocenti Centre, ranking a whole lot of countries, mainly high-income countries, on inequality in education, child poverty, child well-being. And as you can see, Australia, despite being one of the richest countries in the world, has some of the poorest outcomes compared to other countries. The other thing I just want to sort of lean into is this idea of inequity. And I've kind of got to throw a whole lot of ideas at you because I think they frame this conversation. The first is this idea of inequitable outcomes. And in this case, they're driven by systemic and potentially remedial differences. And I really wanted to hold that idea of what do we mean by inequitable outcomes being systemic and potentially remediable. And at the same time, I wanted to think about inequitable delivery of both our policy and services. And you can see from this, this is Australian rules football. I'm actually a Richmond supporter, but you can see I had no say on these slides. So you can see with equality, everyone getting the same, we actually get unequal outcomes, and longer conversation as to why that happens. Equity means we're actually delivering to need to get equal outcomes, and reality, which I'm about to show you, looks very different. So let's lean into the challenge. Here are the Australian Early Development Census results for Australia. I could have shown you New South Wales, they look pretty much the same. So there's some really stark things here. First of all, just over 50% of kids are thriving. In other words, they're doing well on every of the Australian Early Development Census, a population measure of child development school entry since 2009. The other one I really want to bring your attention to is the purple line, which is children developmentally vulnerable on 2 or more domains. And this should be of real concern to you because if you're starting school developmentally vulnerable on 2 or more domains, your chances of succeeding at school and really kicking goals are far diminished. And then on top of that, we have these inequities that have almost been immutable. So again, developmental vulnerable on 2 or more domains between the richest areas at 7.6%, so not zero, but 1 in 5 kids in our poorest areas are turning up developmentally vulnerable on 2 or more domains. You cannot solve for that prevalence by tinkering at the edges. And then the
Sorry
other
to interrupt, Sharon. Do you mind taking control to move the slides? I think
I have
been moving through. Oh. Thank you. Sorry to interrupt.
Did you miss all my other slides?
No, so we were moving through them, but it's probably easier if you move them so we know when to move next.
Right, I did that fatal not do that piece. So even though they told me 4 times to do that, I still didn't do it.
Thank you.
So let's just go back then to the ADC. On your right-hand side, you can see the children with special healthcare needs. So in the ADC, we say, hey, is there something going on for these kids? Poorest areas, 28%. And the 2 commonest, I know you're not going to all fall off your chair, language and behaviour. And then look at what happens as children track along. These are some work that's been done looking at what happens to children as they track along between high and low SES children. And as you can see, this is the Matthews effect. The rich get richer and the poor get poorer. Higher income kids kick goals, lower income kids lag behind. So where you start is where you keep tracking. And we have inequity in our service delivery as well. This is work done by Kim Dalziel, looking at proportion of Medicare spend. You look at GPs, it kind of looks, well, that looks pretty even, except that their highest morbidity load is in our lower income places, so that should be higher. I'm a specialist, I'm part of the problem. You can see the lower income kids who have the higher need have the lowest uptake of specialists. Now, this slide is not designed to kind of be talked through, but I'm showing you the patterns of how inequity gets under the skin in both the adults and the children. This is data from the longitudinal study of Australia's children, including things like telomere length, which is in the bottom right there. So essentially, inequity is not just a social policy issue, it is a chronic disease issue. Inequity gets under the skin, you're more likely to see issues of chronic disease emerging early, and these children then die younger as adults. Now, I put this together with AI, so it comes together with the AI caveat, but it's kind of cool. I asked AI, how much are we spending per child 0 to 8 across all areas of health, education, social, disability? And I think that the numbers might be dodgy, brothers. The direction's probably right. And then at the bottom is the ADC, developmentally vulnerable on 2 or more domains. And you can see that our public spending is going up, and our developmental vulnerability is going up as well. In other words, despite spending more money, we are not shifting the dials on the things that are important for children. And I put this as a provocation. So the final thing here to say is this is the biggest giantest canary in the coal mine I can find in terms of data. This is Mr. Daydream, in case you're wondering. But this is our human capital being squandered in Australia, and we cannot afford to squander our human capital. So what's the opportunity? These are our gold medal tally results. This is the gold medal tally results for the Paris Olympics. Australia came 4th. Little pissant Australia, 26 million people, 4th. So that tells me we are the potential as a country to do amazing things. The other thing is our immunisation results have equitable outcomes. We have the same immunisation results for Aboriginal kids, poor kids, rural kids. We can do it. So I want you to get a sense of what's possible. Now, to do that, we need to think about a few things. First of all, this kind of ecology of childhood. Children live in families, families live in communities, communities live in society. This is based on Bronfenbrenner. That's the first piece of thinking. The second is this ability to hold 2 things, the N of 1, the individual child and what happens to them. And many of you are probably practitioners online. That is important. Do not discard that. At the same time, how do we keep populations of children healthy and developed? Now, Mencken, who was a kind of 20th century commentator and philosopher, says for every complex problem, there is a simple solution, and it is wrong. And so the question is, how do we kind of live in that complexity? So what should we do? What could we do? Here are some provocations. The first is we cannot discard the social determinants of health, those upstream determinants like income, social human capital, employment, and you can see health services only contributes 10% in this work done in Western Europe. The second is we've done some work looking at what happens if you model getting rid of disadvantage, and it turns out you eliminate 50% of the problems for kids. So leaning upstream is still going to be really important. If we just go downstream, we won't make the difference. The third is that I would love to say if we just target some really poor areas, all will be good. But actually about 30% of kids living in poor households do not live in poor areas. And so if all we do is target geographically, we'll miss a lot of the kids. So we need universal and targeted approaches. And there are no silver bullets. I would love to sit here and go, thank goodness I'm here. I've answered, just do this one thing. And instead, we need to think about this idea of stacking, which is what we've been working on. This is Changing Children's Chances, which is looking at how do you model this stack. But everything you see in that stack are things that are already available for families. They're just not delivered equitably to the right people at the right time. And then finally, there's the pressure cooker. How do we do slow food fast? We use a pressure cooker. My challenge to you is how do we do slow system change fast? We cannot wait for the next 10 years to change outcomes for children while we squander human capital. So moving beyond the rhetoric of all of that, what should we do and what could we do and how do we move beyond just good intentions? So I want to talk about the N of 1 for a moment. And I particularly want to talk about children in out-of-home care and their healthcare needs. This is work that was led by Karen McLean, who's a paediatrician, was my PhD student, looking at the dissonance between what we should be doing in terms of seeing children out of home care and the healthcare system. And it's the difference between, you're supposed to see all kids are supposed to see a GP by 30 days. You can see it's just over 30%, and it's not even 100% by 12 months. So there is a writ large disconnect between what we need to do policy-wise and what we offer the most vulnerable children in our community. And I wanted to give you just a sense of what you can do. This is now the Victorian Centre for Health Leadership for Children in Care, and Pathways to Good Health for Children in out-of-home care has been set up across the state. So making a difference to the N of 1 is still important, particularly for those who are most vulnerable. But how do we keep populations of children healthy and developing well? Well, the first is developmental promotion, and just a plug for the Raising Children Network, which is an evidence-based parenting website around a whole range of things, of which child development is one of them. So in the child development promotion space, we have some things in place. We've also been trialling mental health in primary schools, which is how do you uplift the mental health literacy of teachers? Because it turns out the kids go to school 5 days a week, 5 days a week, 7 hours a day, 40 weeks a year. How do we make the most of making sure health is being thought about as a 21st century skill, and how do we uplift teacher capacity? Mental health in primary schools is showing that. And this is the sort of evidence around it. And you can particularly see 90% agreed that mental health in primary schools increased their confidence. Early detection, and this is writ large happening in the kind of thriving kids world. Developmental screening is part of that. You'll be very sensitive to that in New South Wales as well. There's the PEDSAR, but there's also work that you're doing in New South Wales. But I want a particular plug for ASQ Track, which is an Aboriginal adaptation of the ASQ, which is an international tool for developmental screening. The one thing I will say, developmental screening of the population requires 100% of the population in the denominator. It's not those people who came through. It's not those people you think are at risk. It is 100% in the denominator. And I think if we can do that, then we're much more likely to have developmental screening as part of a robust part of an early detection system, noting that developmental screens are all fatally flawed. They all have sensitivities and specificities at the 70 to 80% mark. Now, prevention and early intervention. You remember I talked about before, how about if we just provide things universally, we get disproportionate uptake of the middle class. Proportionate universalism coming out of this kind of work from Michael Marmot says we want to focus, if we focus just on individuals that experience the most extreme levels of diversity, we will not reduce health inequalities. And it's this idea of providing things with a scale and intensity that is proportionate to the level of support needed by each individual, but from a universal base. And that is proportionate universalism. And this is the kind of way it can be used in a child and family health system in terms of what does everybody need all of the time, universally, 100% of families in the denominator. What needs to be targeted, 10 to 25% of families in the denominator where you're responding, and what's sustained, like sustained nurse home visiting. And in fact, some very groovy things we've been doing about how do you bring together those social determinants, finding the families that have actually got a need in the poverty space and together with a universal child health system. Healthier Wealthy Families is a Scottish program. We've done a pilot of this, and it turns out if you ask families if they're in need and do a warm referral to a financial counsellor, you find all these entitlements they haven't had to the tune of $6,500 more into people's homes, plus reducing stress and increasing financial knowledge. Watch this space. It's being led by Anna Price. There's a cluster randomised control trial going ahead in Queensland. Again, better use of the existing system. And Right at Home, which is based on MESH, the New South Wales model. This is the randomised control trial that was done in Victoria and Tasmania. And let me tell you, blow me down. I've never done a trial before that have actually had these sort of outcomes. Usually all my universal trials come up with nothing. So this is showing that at 2 years, not only at 2 years did we show immediate benefits to the parenting and family, but also 3 to 5 years later, we were still showing outcomes. And at 6 years, a difference between the control and intervention children, particularly around mental health and executive functioning. You're already doing MESH in New South Wales, and this is being rolled out in Queensland. And then a little plug for National Child and Family Hubs. So there are lots of hubs all over Australia. You can see the little dots there. There's about over 400. And the National Child and Family Hubs network is saying, hey, there's all these different front doors. There's community health front doors, there's primary care front doors, there's ECC front doors, primary care, primary schools, and we're doing virtual work as well. How do we harness that so we're learning about these hubs? And how do we do what seems very sensible, doesn't it? Which is parents going through one front door to meet their children's needs and their own needs. And of course, in the virtual space, we've developed a child and family e-hub. This is a prototype phase, but again, how do you develop digital solutions that are equitable, co-designed with end users? And as you can see, a tiered approach here that takes you everything from universal right through to a filter system, right through to a chatbot, and then actually somebody. And we've had a lovely evaluation of this that say people really value this, and a hint that says, hey, I can actually get my healthcare needs delivered through an e-hub and realise I actually have social needs that are not met, and look for that. And then address developmental inequities. Hot off the press, actually, we've just had a paper on this, but you can see this idea of a data logic. How do we get the right data in the hands of the right people at the right time? And just very quickly, I'll go through some of this. This is the hot off the press MJA insight for those who are interested, and it's a summary of this paper. So we already talked about lag indicators like the ADC, but I want to give you a sense of why these data are important. So lag indicators tell you how things are tracking over time. This is very useful. This is by 5, which is an early years initiative in the West Wimmera, which you can see there in Victoria. And what they did was use telehealth, community consultation, and also getting together case conferencing to look at children's development. So using a paediatrician in Melbourne. And blow me down, this is their ADC results. There's the orange line there. A lot of blowing down, isn't there? You can see the ADC results actually improved. Now, I can't put hand on hearts to say this is causal, but I don't think it's coincidental. So lag indicators are important for telling us how things are progressing over the time, but they don't tell us what to do tomorrow. For that, we need lead data, and this is restacking the odds. It just says, could we get 5 things right for children? Just 5 things. And these are the 5 things: antenatal care, sustained nurse home visiting, parenting programs, early childhood education care, and early years of school. And to do that, we ask 3 questions. Is there enough? Is it any good? And do people come? And putting data in the hands of frontline providers, and particularly around quality improvement. And then also we need cohort data for modelling equitable policies. Changing Children's Chances, as I mentioned previously, is looking at what are the right policy levers that are needed to close the equity gap. And again, cohort data telling us something about outcomes for children. And then finally, research and practice to policy. I just want to stop here and say what an extraordinary moment in time it is for Australia. These are all the things that are going on at a Commonwealth level. I didn't map all of New South Wales. I thought that was a bit presumptive of me. So this is what's going on in the Commonwealth. These are all things for which there is more or less some money involved. And I just want to note this point of time where there's this extraordinary opportunity to converge our effort about the same children, and just note that important opportunity in time. I think this is the moment for us to do the pressure cooker thing, to do slow system change fast. And I'm really hoping that we can deliver on that for kids. So this is my final slide. So everybody's going, oh my God, she actually finished those slides on time. This is from Don Berwick. Don Berwick was at the forefront. In hospitals, we're busy killing people. People notice that, or maiming them. People notice that too. And so we're chopping off the wrong arm and leaving instruments in people. And so quality improvement in the hospital sector really took off. And Don Berwick was the front of that. We're now trying to do that same quality improvement in the community sector. How do we actually drive community and quality improvement in the community sector? But I like this. I want to read it out because all of you online are the leaders that we really rely on. And it is the burden on good leadership to make the currently unthinkable thinkable, to question the obvious, to make the present systems unavailable options for the future. The boundaries in our minds create fear about the consequences of crossing over to the undiscovered country, but the possibilities we really need do not lie on this side of our mental fences. And once crossed, these fences will look as foolish in retrospect as a belief of other times now often look to us. And that is the end of my slides. The snapshot is just there for those of you who want it, because the slides will be available. This is the stuff that we're doing at the centre. And now I know not to touch this because I'm going to hand it over to Christine, and I'll look at some of the questions. Thank you for the lovely emojis. That always makes you feel good when you're doing a webinar. And I'll hand over to Christine.
Okay. Okay, thanks, Sharon. That was amazing. And I'm going to change tack completely, I think. And I think in many ways, disability is the poor relation. And I'll talk about that a bit, but we just don't have that level of investment and level of evidence behind what goes on in the disability sector. And it shows, I think. So thank you so much. I'm going to talk about quality services in a more general way in terms of what does it mean and how do you measure quality services for adults predominantly with intellectual disabilities. Here we go. So if you look at the policy aims of the Disability Reform Council, which is the government body that's sort of looking after the entire disability system, it talks about the aim is to design and fund a disability ecosystem that provides high quality, effective and safe services for people with a disability. So the thing I'm going to talk about then is, well, what do you need to know in order to design and then to measure quality services? And you need to know in many ways what Sharon's talked about is what does the evidence say? What does good look like? What are the expected outcomes that you're trying to achieve for individual people? And what are the practices that support those outcomes? And what are the organisational conditions that facilitate the outcomes? And once you've worked those things out, then you've got to work out what are you going to measure. Are you going to measure the direct outcomes for individuals, or are you going to use evidence-based indicators, process indicators of outcomes, which saves you measuring each individual outcome? The disability sector has some very specific challenges. It is very high on ideology. It knows what it doesn't want. It knows what's not quality. It doesn't want institutions. It doesn't want restrictions on people's rights. It doesn't want harm to happen to people. And it's very high on outcomes that are pitched at very high levels of abstraction. It talks about rights, inclusion, autonomy, very high level things. It's high on individuality in terms of person-centeredness. And that means that outcomes expected and practices have to look different for each person and each group.
The disability sector is incredibly low on evidence compared to almost every other community service sector. Up until probably the last 20 years, maybe 15 years, there was almost no interest in the disability sector in terms of research. There were so few researchers working on this type of what practice produces what good outcomes. And the disability sector is also very high on diversity. People with disabilities are an incredibly diverse group of people in terms of the types of impairments that they have, the severity of those impairments, and obviously the types of social obstacles, therefore, that they have to overcome. But they're also very diverse in terms of voice. Who do you hear from? Some people have very loud voices. Some people have almost no voice at all because of their cognitive impairments. So I'm going to talk a bit about particularly focusing on people with intellectual disabilities. In terms of the quality outcomes that we expect for individuals, we often talk about that in terms of the realisation of people's rights. We use human rights and this high abstract idea of rights. We sometimes talk about, and the NDS has introduced this, reaching individual goals. But the problem is that goals are very hard to measure and they're often very poorly formed. And we know for adults with intellectual disabilities, they're often decided by other people. So they're not that person's own goals. We talk about satisfaction, but the problem is if you measure satisfaction, it's really not helpful because most people are satisfied for most of the time, irrespective of the sort of circumstances in which they live and the quality of their services. The most commonly used idea about outcomes is quality of life, which maps very clearly onto rights, but is much more, there's much more research about how to measure, how to think about quality of life for different groups. And importantly, the concept of quality of life means that it has subjective and objective elements. So you may be able to measure some objective elements that are the same for everybody, but it basically looks different in its subjective nature. So social inclusion is a high level indicator, but what that looks like will depend on each individual's preferences and their own circumstances. So it's incredibly hard to measure something like social inclusion as part of somebody's quality of life. It's very hard for people, many people with disabilities to use surveys, which are use complicated language and you need to be able to use scales to indicate gradations of things. There's a high reliance in disability on proxies, on what other people think about somebody's quality of life. And the problem for service providers in the disability sector is that they're trying to support somebody's quality of life, but they're often only responsible for some parts of it. They're not totally responsible for quality of life outcomes. So it's incredibly hard to measure the outcomes that you're trying to seek for individuals in the disability sector. We've done quite a lot of work trying to translate quality of life domains for people with intellectual disabilities who are living in supported accommodation services into very clear things that you would expect to see for people, you would be able to ask them about or to even observe or to ask other people who know them well about. And I'm not going to read through these, but it is issues like personal development, interpersonal relationships, community inclusion, obviously self-determination, rights in terms of feeling heard, having people to speak up for you, having physical well-being, material well-being, and emotional well-being. And all of those things together need you to be engaged. They need you to be engaged in everyday activities and in social interactions with other people. So the level of engagement that you have as a person with intellectual disability is really a pivotal indicator about people's quality of life. And that's the indicator that we've used in most of our work for people with intellectual disabilities in supported accommodation. So if you're thinking then about, well, what's the quality of services that can lead to quality of life outcomes, This is also problematic because it's often framed in terms of users' expectations. Does it meet somebody's expectations? Well, the problem is people often have low expectations because they've had such poor services in the past, or their expectations are unexpressed. They can't express them. The other way in which we've done it, and increasingly we're doing it, is through regulatory standards. If you look, this is a quote from the recent standards. Participants are safe from violence, abuse, neglect and harm while being supported to have choice and dignity. That's great, but how do you measure that? That's focused on a set of very abstract ideas that you're trying to measure for quality services. And the way we also do it is to look at the number of things that are present, so incidents, how many incidents have there been, or the absence of things that are already measured. How many complaints are there? So we make a lot of use about process indicators, which are administrative indicators, and most of those are actually not evidence-based. So there's no evidence about the relationship between complaints and the quality of services, or incidents and the quality of services. And some people would actually argue the more reported incidents there are, that's actually an indicator of a quality service, because people are much more aware of when things are going wrong and are more likely to pick it up. So in having talked about how hard it is to measure quality, I did a literature review a couple of years ago for the NDS Quality and Safeguards Commission about what you would expect to see in terms of evidence-informed practice that was relevant to people with supported accommodation. And there's some very clear evidence-based practices that we do know, but the problem is they need to be relevant to the people that are being supported. So these things, active support, enabling risk, support for decision making, those things are very relevant to people with intellectual disabilities. They're not particularly relevant to people without intellectual disabilities. So you have to select evidence-based practice that is relevant to the people with disabilities that are being supported. Therefore, if you're an organisation that's supporting a whole range of people with disabilities, your practice framework needs to represent different evidence-based practices for different groups of people. There isn't one set of practices that will lead to good outcomes for all people with disabilities. In intellectual disability, active support is the evidence-based practice for which there is strongest evidence. If you use good active support, that makes the most difference to people's quality of life. And basically, it's an enabling relationship between staff and the person that's being supported that enables their engagement in meaningful activities and in social interactions. In order to do good active support, you need to know the person really well. You need to be attentive to their preferences and understand their individuality and their level of adaptive behaviour. The evidence about active support has been developed since the early 2000s. It was developed as a practice in the UK, and then we've been tracking its implementation since 2009 in Australia. And it's an example, I think, of the way in which you need to develop evidence about good practice and the outcomes that it leads to. So we originally analysed and described its components. We've understood its effective training approaches. We've understood the factors that predict good practice. We've understood the factors that affect implementation. And we've translated the research measures now into usable forms that organisations themselves can use to measure and track good practice. And it takes a long time to go through that whole cycle of understanding what's necessary for implementation. You actually have to have a lot of good practice in order to do that. And that's part of the problem. If you don't have good practice out there, it's hard to learn what you need to embed it in services. Hang on. I'll go over that. So we've developed a tool called the OPQ, which is a measure now that can be used by internal auditors in organisations and by frontline managers in terms of what should you see, what would you expect to see if staff are providing good quality support. And those are the items. There's 8 very simple items that you can score from 1 to 3, and they reflect what you should see in good active support practice. And it's an app, it's easy to use, but what it has done is enable organisations to track the quality of practice over time using observation, using that evidence, not relying on paperwork, secondary reports, and the existence of policies. And so for the first time really in disability services, the managers at the front line are able to report on the quality of practice up to the boards. So it puts front and centre to boards of management, to senior executives, this is what we're trying to achieve. This is the quality of practice, the same as this is what the balance sheet says this month. So it helps to focus attention on the significance of practice to the outcomes that organisations are trying to achieve. I left off all the figures from this, but this is a summary of a path analysis that we've recently published, which shows very clearly that practice leadership, size of services, a culture of supporting wellbeing directly influence the quality of active support, the 2 types of active support, and they directly influence the level of engagement of people with intellectual disabilities. And just to go back, what gets in the way is things that you can't influence, which is the level of people's adaptive behaviour and people's age. And those things you need to pay particular attention to when you're training staff in how to adapt your practice to take account of people with higher support needs. We've found over time, forever, that people with higher support needs have poorer practice. So we need to train people to take that into account and to really focus on adapting their practice for people with very high support needs. And then finally, we've taken that knowledge that we've developed about predictors of good support and folded it into an implementation framework from implementation science, which then gives organisations a very clear set of things that they need to do to embed active support within their organisation. And we've unpacked the detail under each of these headings, but it gives them a framework for thinking about they need competency of staff and managers and boards. They need organisational drivers to get the right processes and structures in place, and they need leadership drivers to ensure that there's a focus on practice and on quality outcomes rather than just on the bottom line. And I think I'm running out of time, so I'm going to hand over in a minute. I just want to say that in the disability sector, there's a lot of things that get in the way of creating and using evidence. And one of the things is the failure to recognise specific knowledge for specific groups. The insufficient good practice that we have in the sector, which means it's very hard to learn from good practice because you need large samples. And we continually reinvent concepts and rebadge concepts as if they're new, rather than sticking at things and developing them over time. So I'm going to hand back now. There's some resources and references in the slide set. So it's all yours.
Thank you so much, Christine, and thank you to Sharon as well. 2 really wonderful presentations giving practical advice backed by good quality evidence, both at the system level and at the organisational and practice level, so across the life course. So really fantastic and far-reaching. So I'd now like to bring us to our Q&A session with our panel members, Fiona McEwen, Manager of Service Design at the New South Wales Trustee and Guardian, and Catherine McKenzie, the Director of Operations in the New South Wales Ageing and Disability Commission, who I introduced earlier. And please, just a reminder, if you have questions, I can see some in the chat. If you do have more questions and we have some time at the end, I'll come to those. So please put them in the chat. And firstly, I'd just like to ask Fiona, so reflecting on the research presented and the findings that you've heard today, what role does service design play in supporting service quality at the New South Wales Trustee and Guardian?
Thanks. I also, absolutely acknowledge that the presentations and the work presented by Sharon and Christine has a lot of application and resonance for us. And for me, the bits that really stood out were around that evidence-based, or setting ourselves up to have an evidence-based practice or service design, but also making sure we're measuring the outcomes that actually matter to people, and that's different for everyone. And I know that comes up a lot in the research we do at Trustee and Guardian, particularly with customers that are under financial management or guardianship orders. And I think for me, we're in our early days of our journey in service design in our organisation, but we see our role as being a facilitator of the continual improvement cycles rather than just a one-off project. We like to try and connect the dots between, say, the frontline staff and customer experiences, but also highlight the organisational levers and structures that need to exist, or the conditions, I think Christine mentioned, that actually allow us to sustainably listen, learn and act in a cycle in the future. So a lot of our projects have really been about building our capabilities in that area. And one that really sticks out is probably, something as simple as feedback. It is certainly not simple in our context. And before deciding to survey customers and do things that probably aren't the most inclusive or accessible, we had the opportunity to actually do research with a wide range of voices to understand the barriers to providing feedback, but also what are the service moments that really matter to our customers, so that we're not looking at things that won't have impact. And then our role afterwards is really bringing the insights back to our teams and translating them in a way that it's useful and that they can make sense of it and actually come up with their own ideas, of which are multiple, because there is no one silver bullet, as Sharon said. How do we test and learn with lots of those ideas across process and tech and outreach, and what does that look like for us? So for me, there was a lot of resonance and relevance for what we encounter.
Thank you. And some of this is touched on, but how can organisations better understand and respond to people's needs across services?
I think for us at the moment, we're doing a lot of work to really bring together a more holistic view of our customer needs across our different teams, and also in the future across different services. I think Christine mentioned that, we are only part of one bigger outcome for our customers who are experiencing their own lives, not all the individual services. And, service design projects can help teams see the whole person across the services and the interactions rather than just a siloed moment. And that helps people on the front line with their practice understand the impact of that beyond their sphere. And so right now we're developing an organisation-wide service planning framework, which helps develop one shared view of all the different customer needs, particularly for those who are under orders, because they are usually customers of multiple different teams in our organisation, and look at what service quality means for them in those different groups. And at the same time, strengthening our systems and how our people and external relationships work together to coordinate service responses. I think that just helps for the better outcome, but also safeguarding understanding as well. Ultimately, for us, I think we're also interested in projects that look at the service outcomes upstream. So, how can we don't want to be, we want to be the last resort of decision making for folks. And, how can we encourage more people to undertake planning ahead documents, like making a will or enduring guardianship, so that they can choose who supports them should it come to that down the track in their lives. So for us, it's not just the frontline practice, it's also looking at the system as a whole and saying, where can we create outcomes that mean people don't have to become under orders?
Thank you, Fiona. We'll make sure we share some of those resources that you've developed and the ones that are under development on our webpage, where people can access this session. And questions for Catherine McKenzie. So how do the topics and points covered by Professor Goldfeld and Christine Bigby link to the role and functions of the New South Wales Ageing and Disability Commission?
Yeah, thanks, Jess, and hi, everyone. Really good to be here. So I'll just start by flagging, I guess, the main roles of the Ageing and Disability Commission, primarily about seeking to better prevent and also responding to reports about abuse, neglect and exploitation of adults with disability and older people in New South Wales, primarily in family, home and community settings. And we've also got the function of operating the official community visitor scheme in New South Wales. And I thought the part of the piece that was really relevant to the work of the ADC was in relation to Christine's presentation and service quality in disability environments. So the community visitor scheme essentially is independent ministerial appointees who visit people living in residential care in New South Wales. Primarily that's disability accommodation services, NDIS funded services, but also assisted boarding houses and also children and young people living in residential care and out-of-home care in New South Wales. I think part of the challenge, and Christine very well covered a lot of this, but part of the challenge that we see in terms of the delivery of services, certainly in residential care environments or accommodation environments, and what is used as kind of the evidence of good service practice is heavily kind of audit friendly information. It is kind of highly administrative information that's used as evidence. I think in part some of the regulatory approaches and models seek to drive some of those responses. But part of what I wanted to illustrate today was the role that community visitors play in seeking to provide other evidence, other information that can be used as indicators of positive or good practice in relation to service providers, and giving a focus on what is the lived experience of the adult with disability or for out-of-home care, the child or young person in those services. And really what the community visitors are doing, there are kind of practice standards, there are kind of benchmarks around what is considered to be quality in the services, but really what the community visitors bring is a lens that's focused on what are the community standards here. So what would I expect if I was in that service? What would I expect for family member or other loved one in this service? And really critically, what is it that the adult with disability wants in terms of outcomes? What is their day-to-day experience? And the OCV is kind of focused on that and raising where service delivery doesn't match what would be expected to be positive or what good looks like. So often we kind of see, and the visitors see, it's the voice of other people that is the driver around what good quality looks like. And, that focus that I know Christine mentioned earlier around, that focus on, preventing bad things rather than kind of making good things happen, and less about, the actual direct experience of the resident, which is very much the focus of the community visitors, cutting through as much as possible of that to go, what is the actual experience of the person? What is it that they want? Hearing directly from them wherever that's possible, and using that as the driver of ways to kind of improve practice.
Thank you so much, Catherine. We've only got a few minutes left, so I might go to some of the questions that we have in the chat, and thank you to people who have been putting those in. Firstly, Sharon, there's some questions and comments there around access, which I can see that you have responded to, but just if you had any further points around access for people with disability and also making sure that services are inclusive and involving people from culturally and linguistically diverse backgrounds. Is there anything further you wanted to add?
I just want to say there's this thing called the cut curb effect, which is basically what happens when we get to the curb where there's the traffic light, whatever, the curb is cut. That actually came out of disability design, but of course it benefits everybody. And I just want to really kind of I guess, ram home the importance of designing with equity from the start, and that we almost never retrofit equity very well if we don't design it in from the start. And that's just a really good example of how, if you design with equity from the start, it actually benefits everybody, both the groups it's designed for, but actually for everybody. And that goes for coal groups, low income groups, etc. And I think that goes to the importance of co-design in thinking about how we develop these services or policies, and secondly, the importance of iterating, coming back, using improvement technologies, and not just set and forget.
Thank you, Sharon. There's also lots of thumbs up for a question around the OPQ being free, which you've mentioned there, Christine. Is there anything else you wanted to mention around access to some of the resources that you've discussed today, or their implementation?
The OPQ is free to download. It's an app, but you actually do need to learn how to use it. And there's a training site so that it's easy to use, but you need to get integrator reliability if you're going to use it in an organisation to track the quality of practice. People we found are using it without bothering to do the training, and therefore they're all getting, really high scores. So it's adapted from a research tool. It's easy to use, but you need to work at it to learn how to use it properly.
And thank you. Do you have advice on how they can do that? Is that through your university?
Well, there's online training. You just need to work through it and read the instructions and take the time to practice within your organisation.
Okay. And there's a related question on how engaged is the NDIA with regards to the OPQ being a good practice for the services they fund?
I think there's a real disconnect, and this is one of the problems. There's a disconnect between the funding and what it's supposed to be funding. The Quality and Safeguard Commission is really focused on regulation, compliance and safety, and the focus on safety. Safe services aren't high quality services, but quality services are safe. And I think we need to flip that around and focus on what does it take to fund quality services. But our research shows that actually there's so much variability between supported accommodation services in the same funding context that you can produce high quality services in the current environment if you really focus on that. People always argue you need more, but we've seen more staff since the beginning of the NDIS working in supported accommodation than ever before. So the question is, what are those staff doing? How well trained are they? And who's supporting them to do really high quality support every moment? And that's what's important to people.
Thank you. And such an important point around quality versus safety. There's also a question here about the tag, and just hearing how does the tag hear from clients in their service design?
Yeah, I think there's lots of different ways, and it depends on really the service and the particular thing we're trying to impact. In a perfect world, we have the ability to go to lots of different customers and interview directly, but we know that there are barriers to participating in that way. And also it's, in some services, when we're involved in a lot of, I guess, the crisis end of things, it can be traumatic. So we also look to engage, at a customer advisory groups, the advocacy groups. We've done research and focus groups on a number of occasions with the broader representatives, as well as, where we can, the direct customers and the people that speak on their behalf or support them to speak. So it really just depends on the service and what we're trying to do, but lots of different ways to try and make sure there's representation from the start. I think that was another comment maybe Sharon made, it rather than just starting with the assumption that you make something basically accessible, we're looking at, how can we make sure we understand the complete spectrum of the needs that the people that we're serving first.
Thank you so much. Look, thank you so much to all of you for participating today. It's been a really fantastic session. I'd just now like to go to each of you in the last minute. If you have one takeaway message that you would like to leave our audience thinking about at the end of this session, and I'll start with you, Catherine.
Sorry, I muted myself. Mine is an incredibly basic takeaway, which is, the importance in in having good service design relating to people with disability needs to fundamentally involve people with disability in the design from the outset, not as an afterthought or an add-on.
Thank you. And Fiona?
I'll steal an analogy I think Sharon used earlier, that the silver bullet, there just isn't one. So, the ideas to affect service quality can be small and granular, but also big. So what can we use to test and learn rather than assuming it's one solution?
Thank you. Christine?
I would say I think that it's really important to focus on what are you trying to achieve for who as a service deliverer, but recognise too that there's very different types of knowledge, that there's knowledge that comes from observation, which is critical for those people who can't speak for themselves, who we very, very rarely hear from. There's knowledge from evidence, which is really important to go alongside that lived experience of people. But just take notice of who it is that you're not hearing from and find ways of hearing from them through other people or through observation. We don't pay enough attention to people with very, very high support needs who can't speak for themselves.
Thank you. And lastly, Sharon.
So very, very quickly, I really want to say that equity for Australians is possible, and I think we should do it, and I think we should do it now. And I think we have all the tools to do it, and I think the policy window is open now. So let's just get on with it.
Couldn't agree more. Thank you so much. Thank you so much to all of our presenters, to our wonderful Auslan interpreters. And I really hope that you all have a wonderful day. We will put the link to the recording for today. We'll send that out to you in the next week. We've also put that in the chat, and we'll add any relevant documents and reports, etc. And we hope that you all join us next month for our next Lunch and Learn. So thank you again, and enjoy the rest of your day.